Hello friends, to understand the larynx, its pathologies and the different treatment modalities, it is very important for us to understand the anatomy of larynx. Now many of you students find that this anatomy is a very tough anatomy and they don't like this anatomy. However, I believe that the larynx is one of the easier topics as far as the anatomy is concerned in the whole ENT. Okay, for that we have to disintegrate the larynx and study each and every part of the larynx. So once we disintegrate and then we systematically combine them together, we can understand the whole anatomy of larynx in a very simple way. So that will be my aim in this topic. Alright, so let's start with the topic anatomy of larynx and let's come to this diagram first. So what is this diagram? Alright, so we can see over here the nasal cavities. There are two nasal cavities. Below the nasal cavity we have the oral cavity. Now we know behind the nasal cavity we have the nasopharynx. Behind the oral cavity we have the oropharynx, and below this oropharynx we have the hypopharynx. Now anterior to the hypopharynx we have the larynx, the voice box. Alright, and below the larynx we have the trachea. Also below the hypopharynx we have the esophagus. So this is the upper aerodigestive pathway. Alright, it's a common pathway for food and air, the pharynx, nasopharynx, oropharynx, hypopharynx, and then it segregates into the airway anteriorly, the larynx and trachea, and the digestive pathway, esophagus, posteriorly. Alright, now what part we are going to study over here? We are going to study this part, the larynx. Right, so this is our larynx. As you can see that this larynx, this is a cartilaginous structure. Okay, and this is the airway. Okay, you can see the laryngeal inlet, the air going into the larynx from the hypopharynx. We can see over here some cartilages of larynx, epiglottis, thyroid, cricoid, and below that we can see the trachea. Alright, so now this larynx is situated at the level of C3 to C6 cervical vertebra in case of adults, and it is situated at the level of C2 to C4 vertebra in case of neonates. So in neonates you can see that this larynx is situated higher, much higher than the adults. Now what is the advantage of this? The advantage of this to the neonate is that the neonate can drink and breathe at the same time. Okay, so when the newborn is sucking the milk from the mother's breast, he does not have to dissociate itself again and again to take a breath. Okay, the neonate, the newborn can keep on breathing at the same time, keep on sucking the milk. Now the same thing, we cannot eat, adults, we cannot eat and breathe at the same time. If we try to do that, the food or the water will go into our airway and that will induce a coughing reflex. Right, that's because our larynx is situated lower as compared to the larynx of a neonate. Okay, now how many cartilages are there in the larynx? So as we saw that this larynx is a cartilaginous structure. It consists of how many cartilages? 3 unpaired and 3 paired cartilages. So total number of cartilages are 9. Okay, so larynx has 9 cartilages, 3 unpaired and 3 paired. So what are the unpaired cartilages? We just saw epiglottis, thyroid and cricoid. The 3 paired cartilages are arytenoid, corniculate and cuneiform. So what we will do is we'll study each of these cartilages separately. So as we say, I will first disintegrate the larynx, we'll study each of these components separately and then we'll combine them together. Right? Okay, so let's first start with the epiglottis. So as you can see over here, this is the epiglottis. It is a thin leaf-like cartilage. Okay, this cartilage is made up of elastic cartilage. So we know what is the advantage of elastic cartilage. It never ossifies. Right, so we have the first cartilage, the epiglottis, and this is a thin leaf-like cartilage, never ossifies. Alright, so it will always remain cartilaginous. Now the next cartilage that we have is the thyroid cartilage. Right, now this cartilage, the thyroid cartilage, this is a hyaline cartilage. Now remember, the hyaline cartilage ossifies, it becomes bony with age. So in old age, if you do an X-ray, you'll find that there is some bony parts in this cartilage. Okay, it will become hard, it will become bony with age. Now let's look at this thyroid cartilage. This thyroid cartilage is like a shield. You see, it's like a shield. It has two laminas, the right lamina and the left lamina, and it is covering the three sides. So remember, if you see old days movies, when there were kingdoms and wars, so the soldiers used to go to fight, and they used to carry different kinds of shields. Some of the shields will be, circular shields, and some of the shields will be just like the thyroid, covering on the three sides, right? So this is a shield-like cartilage covering the three sides. There are two laminas, right and left. They meet in the center. Now each lamina, you can see over here, it has a superior cornea or superior horn and a inferior horn, right? The two laminas are meeting in the center where they form a superior thyroid notch and inferior thyroid notch, and there is a laryngeal prominence or protuberance. Okay, now where these two laminas meet in the center, they form an angle. This angle is known as thyroid angle. Okay, and this angle may range from 90 degrees to 120 degrees. 90 degrees in males and 120 degrees in females. Now because this is a very sharp angle in males, that is why it gives the appearance of Adam's apple. So you see over here, the Adam's apple is because of this laryngeal prominence of the thyroid cartilage. Okay, so that gives the appearance of Adam's apple, especially in case of males. And this question has been asked, Adam's apple seen in boys is because of, an answer now we know is thyroid cartilage, right? Okay, let's go ahead and look at this cartilage, the third unpaired cartilage, cricoid cartilage. Now what do you see over here in the cricoid cartilage? You see this cricoid cartilage is a ring-shaped cartilage. Okay, it's a ring. Now see, this is the only complete ring in the whole human airway. Okay, so this is important because this is the only complete ring in the whole human airway. Rest all the cartilages, suppose we saw the thyroid cartilage, it was open posteriorly, and then you can see the trachea over here. These cartilages are also incomplete C-shaped cartilages. Okay, so these are incomplete C-shaped cartilages. All right, cricoid is the only complete ring of cartilage. Now this cartilage, the cricoid cartilage, is also made up of hyaline. So as we just discussed previously, this cartilage will also ossify with age. So in the old age, this cartilage will become bony. Now this cartilage, the complete ring, like a signet ring, it has, the anterior part. The anterior part is known as the arch. The posterior part is known as lamina. Now this cricoid cartilage, you can see the airway. You can see that there are two facets, one for the cricoretinoid joint and one for the cricothyroid joint on it. Okay, now there are two joints, cricoretinoid and cricothyroid combines the cricoid to retinoid cartilage and thyroid cartilage. Now remember, both these joints are synovial joint. Okay, so MCQ over here, both these joints are synovial joint, right? So these were the three unpaired cartilages. Now let's come to the paired cartilage. So we just discussed that over the cricoid there is a facet for attachment of retinoid cartilage. We have a cricoretinoid joint. So you can see over here we have the retinoid cartilage. This is a paired cartilage lying over the cricoid, and this is pyramidal in shape, right? You can see that this cartilage is pyramidal in shape. This is made up of elastic cartilage, right? Let's discuss them in detail. So these are the retinoid cartilages, paired cartilages in the shape of a pyramid. Now what can we see on these cartilages? We can see that there are two processes on this cartilage. One is the muscular process and the other is the vocal process. Now this muscular process It gives attachment to intrinsic muscles of larynx, right? So most of the intrinsic muscles, I said most, not all. So most of the intrinsic muscles of larynx, they are attached to the muscular process of retinoid cartilage. Okay, now the vocal process, you see, this vocal process, it goes inside the vocal folds. In fact, this forms the posterior 1/3 of vocal folds. Okay, so posterior 1/3 of vocal folds, you can see, is formed by the vocal process of retinoid. Now on this vocal process, you can see over here that there is a depression. Now this depression is for the attachment of vocalis muscle. Vocalis muscle is inside the vocal folds, and of course it is attached to the vocal process of retinoid. Right? Now we can see the apex of the retinoid cartilage. On this apex there is a facet for the attachment of corniculate cartilage. Okay, so we can see this articular facet for attachment of corniculate cartilage. Let's talk about the corniculate cartilage, also known as corniculate cartilage of Santorini. Okay, so let's look at this diagram. We can see the cricoid cartilage. Above the cricoid cartilage there is a pair of retinoid cartilage, and above the retinoid cartilage we have a pair of small corniculate cartilages of Santorini. Okay, now these cartilages are small fibroelastic cartilage, right? So these are small fibroelastic cartilages lying above the retinoid cartilage. Okay, lastly we have the cuneiform cartilages. All right, so we saw over here, you know, the retinoid cartilage. Remember, these were the retinoid. We saw above them are the corniculate cartilage of Santorini, and then you can see that these two cartilages, which appear as if they are hanging in the air, these are your cuneiform cartilages. Okay, now remember, these cuneiform cartilages, they are fibroelastic cartilages once again, right? And they are not hanging in the air. By the way, they look like they are hanging because we have removed all the mucosa and the folds and the muscles and everything. We are just focused right now on the cartilages. These are in the AE fold. What is AE fold? We will be studying in some time, but for the time being we should know that AE fold is a short form for airy epiglottic fold. Okay, that's a mucosal fold between airy means retinoid and epiglottis. Okay, mucosal fold between retinoid and epiglottis, that's known as AE fold. Right, so cuneiform cartilages are inside the AE fold. So we'll study about them later when we'll see the AE fold. Now this diagram, let's look at this diagram holistically. This is the lateral view of larynx. To see all the cartilages, what has been done in this thyroid cartilage over here, it has been, you can see that this thyroid cartilage, 1/2 has been removed, right? So 1/2 you can see has been cut open so that we can see the cartilage of larynx. So what all we are able to see? We are able to see the corniculate cartilage, the cuneiform cartilage, and other than that, we can also see the epiglottis, we can see the thyroid cartilage, we can see over here the cricoid cartilage, and these are the retinoid cartilage. So all the 9 cartilages, 3 unpaired and 6 paired, okay, we can see all of them in this diagram. Now let's look at this. This is the posterior view of the larynx. Okay, so what can we see over here? We can see over here the epiglottis. Below the epiglottis you can see the thyroid cartilage, and below that you can see the cricoid cartilage. Over the cricoid cartilage lies your retinoid, and above the retinoid we have the corniculate, and hanging in the middle we can see the cuneiform cartilages. Alright, so these are all the cartilages of the larynx. Alright, let us now come to this diagram. Now what is this diagram? This is the front view of larynx. Alright, We have the front view of larynx. Now, what can we identify in this front view? Number one, you all can see the thyroid cartilage, shield-like cartilage, right? Now, below this thyroid cartilage, you can see the cricoid cartilage also, all right? Okay, next, you can see that the topmost we have the epiglottis. So, you can see in the front view, we are able to see all the three unpaired cartilages, right? Okay, next to epiglottis, you can see the hyoid bone, right? So this hyoid bone is the only bone in the body that does not articulate with any other bone. So this bone lies in the neck and is attached to the various muscles and ligaments and membranes, right? Okay, now below the cricoid, you can see the trachea and the different tracheal rings also. Okay, now between the hyoid bone and the thyroid cartilage, there is a membrane. This membrane is known as thyrohyoid membrane. Now it's very easy to remember anything in the larynx. The structure is between the two structures, between the two cartilages. We can just club the name and we'll get the name of our structure. Suppose this membrane is between hyoid and thyroid, so thyrohyoid. Okay, so thyrohyoid membrane. Now, in the center, this membrane becomes thick and it forms a ligament. So, we call that as, of course, thyrohyoid ligament. Similarly, between cricoid and trachea, we have a ligament we call it as cricotracheal ligament. Now, please notice over here that this hyoid bone, this is not a part of larynx. It is an external structure. Similarly, the trachea over here is an external structure. So any muscle, membrane or ligament, okay, any muscle, membrane or ligament that connects larynx to an outside structure, such as hyoid bone, such as trachea, now that will be known as extrinsic structure. Okay, you see, thyrohyoid attaches thyroid cartilage to hyoid bone. Hyoid bone is an external structure. Similarly, thyrohyoid ligament. Okay, now cricotracheal ligament. Trachea is an external structure. So it is attaching the cricoid cartilage to the trachea. So it is an extrinsic structure. Okay, so any membrane, muscle, ligament that attaches laryngeal cartilage or larynx to an outside structure is known as extrinsic structure. Clear? Okay, now let's see over here between cricoid and thyroid. What do we see? We can see cricothyroid membrane, right? Okay, what else can we see? We can also see a muscle, that is your cricothyroid muscle. Okay, remember cricothyroid muscle, cricothyroid membrane, both of these structures are between cricoid and thyroid. So between two cartilages of larynx. So structures which are between the two cartilages of larynx, they are known as intrinsic structures. Okay, they are known as intrinsic structures. Remember cricothyroid muscle, we studied in the embryology also. This is the only intrinsic muscle which is formed by fourth arch, not formed by sixth arch. This is the only intrinsic muscle supplied by superior laryngeal nerve, not supplied by recurrent laryngeal nerve. Okay, next question. Cricothyroid, this is the only intrinsic muscle which is present on the external surface of larynx. Okay, remaining all are inside the larynx. So this is the only intrinsic muscle on the external surface of larynx, right? Okay, so now to study the larynx further, what we can do is we can cut the larynx in the half. So you see over here, we have done a sagittal cross section. We have cut the larynx in the half. So we have opened up the larynx. What can we see over here? We can see over here the thyroid cartilage, right? Below the thyroid cartilage, we have the cricoid cartilage, right? Now, below the cricoid cartilage, you can see the trachea. Now look carefully. What I was talking about, cricoid is a complete ring. You can see the cut facets on both the sides. Whereas trachea is an incomplete C-shaped cartilage. So you can see that they are cut only on one side. So cricoid is the only complete ring of cartilage in the whole human airway. Right? Okay, what else can we see? We can see the epiglottis, thin leaf-like epiglottis. Right? Now this epiglottis, you can see it is attached to the body of hyoid bone. So you can see the hyoid bone, the body of hyoid bone, and this attachment is known as hyoepiglottic ligament. Once again, hyoid epiglottis, hyoepiglottic ligament. Okay, now students, tell me whether this is intrinsic or extrinsic. What kind of structure is this ligament? So very easy. We know hyoid bone. What is hyoid bone? This is an external structure. Okay, so the hyoepiglottic ligament, this is a extrinsic structure. Right? Okay, now let's look over here. We can see the epiglottis attached to thyroid cartilage with the help of thyroepiglottic ligament. Now thyroid epiglottis, thyroepiglottic ligament. And what is this? This is between two cartilages of larynx. So this is a intrinsic structure. Right? Clear? I hope this concept is clear to you now. Now, between hyoid and thyroid cartilage, we already have discussed that there is a ligament known as thyrohyoid ligament. And this is of course a extrinsic ligament. Right? That's a extrinsic ligament. Right. Okay. Now, over here, you can see that I have shaded a space. Between these structures, there is a space. This space is known as pre-epiglottic space of Boyer. Pre-epiglottic space of Boyer. Right? Okay. So, let's do one thing. Let's do the boundaries of pre-epiglottic space of Boyer. I've actually taught you the boundaries. Let us revise the boundaries. Okay. So, number one, superior boundary. Okay, superior boundary. Now, what do we have in the superior boundary? We over here have the superior boundary. The superior boundary is formed by hyoepiglottic ligament. Okay, that forms the superior boundary. Now, what about the posterior boundary? You see, the posterior boundary is formed by epiglottis. You can see over here, we have the epiglottis. Right? Okay, anything else? Yes, we have the thyroepiglottic ligament. So, epiglottis and thyroepiglottic ligament together, they form the posterior boundary of the pre-epiglottic space. What about the anterior boundary? So, now in the anterior boundary, you can see that there is a body of hyoid bone. Right? So, number one, we have the body. Number two, you can see that there is thyrohyoid ligament. Okay. And number three, there is a small part of thyroid cartilage. Okay. So, three structures you can see over here, they form the anterior boundary. What are the three structures? Number one, the hyoid bone, the body of hyoid bone. Number two, the thyrohyoid ligament. And number three, we have the small part of thyroid cartilage. Okay. Now, the point to remember over here is that this pre-epiglottic space of Boyer, this is open laterally. Okay. So, this is the pre-epiglottic space of Boyer. It is open on the two sides and where it communicates with paraglottic space. Okay. So, we will discuss the paraglottic space in some time. So, just remember that this pre-epiglottic space of Boyer is open on the sides, on the two sides, where it communicates with paraglottic space. Right? Okay. Let us look at this diagram. Now, this diagram, this photograph, we have already done in the pharynx. Now, what is this diagram? You can see over here the nasal cavity, and behind the nasal cavity, we know we have the nasopharynx, the oropharynx, the hypopharynx. Right? Okay. And then we have the larynx and the trachea. All right. Okay. Now, the air starts going from the nasal cavity, goes to pharynx, and from the hypopharynx, it enters into the larynx and then into the trachea. So, this place over here, this is the laryngeal inlet. The place where the air enters into the larynx. Right? So let's talk about the laryngeal inlet. Again, this photograph we have done in the hypopharynx. So once again, we are revising this photograph. Let us look at the laryngeal inlet. So what all structures are forming the laryngeal inlet? You see, number one, we have the epiglottis. So anteriorly, we have the epiglottis. And posteriorly, we have a pair of arytenoid cartilage. Okay. Now, between the epiglottis and the arytenoid cartilages, this mucosal fold is known as aryepiglottic fold. AE fold. Okay. Aryepiglottic fold. So together, epiglottis, the aryepiglottic fold on two sides, and the arytenoid cartilages, they form the laryngeal inlet. Okay. So this is the ring through which the air enters into the larynx. Right. Now remember, I told you that there are cuneiform cartilages. So you can see the bulge in the AE fold. We have the cuneiform cartilages which lie in the aryepiglottic fold. So these are your cuneiform cartilages that we are highlighting over here for you to understand. Right? Okay. So that is the laryngeal inlet. The air goes inside the larynx. Now what is there inside the larynx? We know larynx is the voice box. Now this voice box larynx, the voice is produced by a pair of vocal folds. So this place where we have the vocal folds, where the sound is produced, that is known as glottis. Right? So this is known as glottis. The part above the glottis is known as supraglottis. The part of the larynx which is below the glottis, that's known as subglottis. Right? So anatomically, the internal part of the larynx, the internal structure of the larynx, we can divide into three parts: supraglottis, glottis, and subglottis. Right? So we are going to study each of these parts separately: supraglottis, glottis, and subglottis. Right? Okay. Now, to study each of these parts separately, we are going to draw a diagram. Okay. I also have a photograph, but I want you all to draw this diagram along with me. Okay, so that you can understand each and every part of the larynx. So in this diagram, we'll try to draw each and every part that we have studied till now and make them as one diagram. Right? Okay, so let's start. Now, to draw this diagram, the first thing that we know is that in the larynx, we have the glottis. Now, what is the glottis? Glottis is the part of the larynx that has the vocal folds. Okay, so I am first drawing the vocal folds. Right? So as you can see over here, I have drawn the vocal folds. Right? Now, these are your vocal folds. In earlier days, we also used to call them as true vocal cords. Now, these names, the vocal cords, we don't call them now. Why? You see over here, do they look like cord? Cord means like a rope, like a string. No, they don't look like cord. They look like folds. Okay, so they are like folds. So that is why we call them as vocal folds. But why were they called as cords earlier? So that we will discuss later. Right? But we know that this part of the larynx, which has the vocal folds, this is known as glottis. And the part of the larynx above the glottis, this is known as supraglottis. And the part below the glottis, this is known as subglottis. Right? We know this thing. Now, I call them as true vocal cords. So if there is true, there must be something which is false. Right? Isn't it? Yes. So we have something false, a structure known as false vocal cords in the supraglottis. Okay. So we actually have a structure over here. So this structure was earlier known as false vocal cords. Okay. So this name is not correct nowadays. As you can see that this is also a fold. So calling them as chords was obviously technically wrong. Okay, so we'll discuss about them. Now, this larynx, as we discuss, it starts at the laryngeal inlet, right? So we know the larynx, the internal structure starts at the laryngeal inlet, and this laryngeal inlet is formed anteriorly by the epiglottis that I have just drawn and posteriorly by a pair of arytenoid cartilages, right? So we can see over here, this is our epiglottis, and posteriorly I have drawn a pair of arytenoid cartilages connecting the epiglottis to the arytenoid cartilages. We have a mucosal fold. This mucosal fold is known as aryepiglottic fold. Okay, so this mucosal fold, this is known as aryepiglottic fold. So this is your AE fold, or you can say aryepiglottic fold, right? And together they form the laryngeal inlet. Now the air goes from the laryngeal inlet inside, right? You can see that the air goes from the laryngeal inlet inside, and this space that I am now shading, this is a part of the airway. You see this shaded area, this is a part of the airway, and this imaginary space over here, we have named it as laryngeal vestibule. Okay, laryngeal vestibule. So what is laryngeal vestibule? So laryngeal vestibule is an imaginary space in the airway. And now where does it lie? It starts from the laryngeal inlet and it ends at the false vocal cords. Okay, so this part of the airway, this is known as laryngeal vestibule. Now remember, because the vestibule, it ends, the lower limit is formed by the false vocal cords. Therefore, these false vocal cords, they have also been named as vestibular folds. Okay, as I said, they were supposed to be called as folds. They were never cords. So now we call them as vestibular folds. Okay, in fact, if you look inside them, you see they are a fold of the mucosa. So when the mucosa folds, the basement membrane inside it also folds, right? Okay, so this basement membrane folds onto itself inside the vestibular folds. You see, this basement membrane folds onto itself and it forms quadrangular membrane. So this quadrangular membrane is inside the vestibular folds, right? This is inside the vestibular folds. Okay, now you see the vestibular folds, they are hanging like this. So because they are hanging like this, they are enclosing a space over here. You see, they are enclosing a space over here. This space we call as ventricle. What do we call it? We call it as ventricle. Now, remember, we talked about the pre-epiglottic space some time back. The pre-epiglottic space is filled with fat. So that is a potential space. It's not a true space. It becomes a space when some malignancy, when tumor enters inside. Otherwise, it's a potential space. Just like the deep neck spaces we discussed in the pharynx. That is, those were also potential spaces. Pre-epiglottic space is also a potential space. Now, ventricle, you can see, however, is an actual true space. Okay. In fact, ventricle is the only true space of larynx. Okay, this is the only true space of larynx, ventricle. Now, what is forming this ventricle? Which structure is responsible for formation of the ventricle? You know the answer. The answer is false vocal cords, which we now call as vestibular folds. Okay, now because they form the ventricle, therefore these false vocal cord, now they are also known as ventricular folds. Okay, so ventricular folds, vestibular folds, false vocal cord, all three are name of the same structure. Is that all right? Okay, so that's clear to everyone. Okay, Now, what all structures have we discussed in the supraglottis? Okay, let's enumerate the structures. All right, so number one, we have the epiglottis. Okay, so you can see these are the structures inside the supraglottis. We have the epiglottis. Number two, we have the A folds on the two sides. Number three, we have a pair of arytenoids posteriorly. And number four, we have a pair of vestibular or ventricular folds. So these are the structures that we have just discussed are inside the supraglottis, right? Now, we know that the larynx is a cartilaginous structure, right? So what do we have? We have the thyroid cartilage. You see, we have the thyroid cartilage covering the larynx on the three sides. So I'll draw the thyroid cartilage over here, right? So this over here, I'm drawing the thyroid cartilage. So this is my thyroid cartilage covering on the three sides, right? Okay, remember this cartilage is a hyaline cartilage. So it will ossify with old age, right? And what you can see, it is covering both the supraglottis and the glottis. Okay, right. Now, below this thyroid cartilage, we have the cricoid cartilage. So this cricoid cartilage is a complete ring of cartilage. So that means you can see over here, it is forming the subglottis. This cartilage, the cricoid cartilage, complete ring of cartilage, you can see it is forming the subglottis. All right. So we can see over here, I'll enumerate them. This is our cricoid cartilage, and above the cricoid cartilage, we just saw that this is our thyroid cartilage, right? Now, above the thyroid cartilage, we have the hyoid bone. Okay, so I'm drawing the hyoid bone. Okay, greater cornea of hyoid bone. So now, from the hyoid bone to the thyroid cartilage, there is a membrane. Which membrane do we have? Yes, we all know the extrinsic membrane. Which membrane? This is the hyoid bone, and from hyoid to thyroid, we have a membrane that is known as thyrohyoid membrane. Thyrohyoid membrane. Okay, now you see this hyoid bone, it divides the epiglottis into two parts. Okay, I'm drawing a line along the hyoid bone, and you can see that it has divided the epiglottis into two parts, upper part and lower part. Okay, which two parts? Yes, suprahyoid epiglottis and infrahyoid epiglottis. Okay, so the hyoid has divided epiglottis into two parts, suprahyoid epiglottis and infrahyoid epiglottis. What is the significance of this? This is significant when we will talk about malignancy of supraglottis. Why? You see, in case of malignancy, you see the suprahyoid epiglottis is just next to the tongue base of tongue. It forms vallicula. Along with the base of tongue, the suprahyoid epiglottis forms the vallicula. Now, if there is a malignancy in the suprahyoid epiglottis and it goes anteriorly, it will go into the tongue base. So that is outside the larynx. Okay. Now, the infrahyoid epiglottis, you can remember anterior to that was the pre-epiglottic space of Poyer. So if the malignancy goes outside the epiglottis, anterior to epiglottis, in the infrahyoid epiglottis region, it will go into pre-epiglottic space of Poyer. And that means it is still inside the larynx only. So the behavior of suprahyoid epiglottis is different from infrahyoid epiglottis when we will talk about malignancy. Okay, so for the sake of malignancy, we have 5 subsites in the supraglottis. So what are the 5 subsites of supraglottis for a malignancy? Suprahyoid epiglottis, infrahyoid epiglottis, ariepiglottic AE folds, pair of retinoids, and a pair of vestibular or ventricular folds. Okay, so these are different subsites in supraglottis for a malignancy. Okay, now let's say we have a glass blower, or we can say we have a trumpet player. Now, a trumpet player has to blow the trumpet. Okay, now to blow the trumpet, he has to generate a lot of positive pressure in the pharynx. You see, the lung muscles are weak muscles. So the constrictor muscles of the pharynx are strong muscles to blow the musical organ. So he generates a lot of positive pressure in the pharynx. To generate this positive pressure, what will do? He'll first close the glottis, okay, so that the pressure does not leak into the lungs. So he'll close the glottis, he'll make the vocal folds come together, okay, and he'll generate a lot of positive pressure over here in the pharynx, okay, and then he'll blow the musical organ. Now, this positive pressure over a period of time, a professional trumpet player, what will happen? It will start going into the ventricle. Okay, so this pressure is going into the ventricle. As a result, this ventricle, it starts growing. You see, it starts growing. Okay, and then there will come a time when this ventricle, it will cross the level of thyroid cartilage. You see, what do we have over the thyroid cartilage? We have thyroid membrane. And then it comes out into the neck, forming a cystic swelling. This cystic swelling in the neck, this is known as laryngocele. Okay, so this cystic swelling is known as laryngocele. All right, so let's look at this laryngocele. So what is laryngocele? As you can see over here, a laryngocele is a air-filled, this is a air-filled cystic swelling in the neck. Okay, and from where does it arises? It arises from ventricle of larynx. In fact, it arises from saccule. Saccule is the anterior most part of larynx. Okay, it is the anterior most part of ventricle of larynx. So saccule of larynx, so there the laryngocele arises. And this laryngocele can be of 3 types. Which 3 types? It can be a external laryngocele, it can be a internal laryngocele, or it can have both the components. Okay, it can be a mixed laryngocele. Just look over here. What we saw was an external laryngocele, or it can grow inside. So it can grow like this. It can be a internal laryngocele, or it can have both the components, external and internal. Now, how will a laryngocele present? How will this laryngocele present? You see, it's an air-filled cystic swelling, so swelling will be visible, right? Now, when we press this swelling, what will happen? When we press this swelling, when you press this swelling will reduce in size. Okay, this swelling, it reduces in size. It's air-filled swelling, and what will happen to air? The air will escape away. So when the air goes out, it produces a gurgling sound, and that gurgling sound of air escape, that is known as Bryce sign. Remember, we discussed Boy's sign. We discussed Boy's sign in Zenker's diverticulum. Okay, so that was in Zenker's diverticulum. We discussed the Boy's sign, that was gurgling sound of fluid escape. And Bryce sign is gurgling sound of air escape, R. Remember R? You can remember R for air. Okay, so Bryce sign is seen in laryngocele. All right. Now, how will a patient of internal laryngocele present? You see, this is an internal laryngocele. Now, how will this laryngocele present? This laryngocele, the internal laryngocele, presents with complaint of cough. Okay, or there may be a foreign body sensation in throat. Okay, sometimes it grows big like this, so it will cause change in voice, or it can even cause difficulty in breathing because it may be covering the airway, so difficulty in breathing. What do you find on examination? You look at this, you will find a smooth swelling. So this is a smooth swelling, okay, smooth spherical swelling of the A fold and the vestibular folds. So A fold and the vestibular folds, right? Okay, how can we confirm our diagnosis? The investigation of choice to confirm the diagnosis of laryngocele is doing a CT scan. Now this CT scan has to be done in Valsalva maneuver. Why Valsalva? What is Valsalva? You ask the patient to close the nose and blow the cheeks. So you are repeating the same thing, you are increasing the pressure in the pharynx. And this pressure will go into the laryngocele, it will expand the laryngocele increases in size and is therefore nicely visible. Okay, so you look over here, this is the CT scan, you can see over here the big nice internal laryngocele, right? Okay, now question asked in the June 2018 exam, laryngocele arises from, we know the answer is saccule, anterior most part of the ventricle of larynx. Okay, this is the CT scan of a patient of laryngocele done in Valsalva maneuver. You can see that this is the thyroid cartilage and this laryngocele is going outside of the neck. It's a case of external laryngocele. Here also you can see. Okay, right. Treatment. The treatment of the laryngocele is by surgical excision. So you can see there is a laryngocele over here and we plan to do a surgical excision. So a skin crease incision is given. And then we will dissect out this laryngocele. So this is the laryngocele which is visible to us. Okay, so we dissect this laryngocele out and then finally in this case you can see the whole laryngocele has been excised. Okay, so surgical larynx excision is the treatment of choice for external laryngocele. What about internal laryngocele? Internal laryngocele most of the times we can remove by microlaryngeal surgery. Okay, what about the mixed laryngocele? Now mixed laryngocele, the external component you have to excise surgically, open surgical excision. So when you are doing the open surgical excision, you go almost till the ventricle. So obviously the internal laryngocele component is also taken care of. So mixed laryngocele once again will go for surgical excision, open surgical excision. Okay, so let's come to this question. A professional trumpet blower. A professional trumpet blower. Okay, so the hint is given to you, trumpet blower. Presents with left-sided neck swelling which is reducible. You see, professional trumpet player, reducible neck swelling. Following is the X-ray finding of the patient. So you see over here, there is a lot of air over here in this X-ray. What is the most likely diagnosis? So you are given the hint, professional trumpet player. Answer is laryngocele. Right? Okay, so remember the laryngocele, it happens in professional trumpet players. It also happens in case of glass blowers. So glass blowers, they give the shape to glass when it is hot by blowing into it. So professional glass blowers. Also it can happen in case of weightlifters. Why weightlifters? Because the weightlifters also do this thing, they lift the weight. While lifting the weight, while doing the deadlifts, they create a positive pressure in the pharynx. So again, it can cause formation of laryngocele in the professional weightlifters. Right? Okay. Now let us go back to our photograph or our diagram that we were drawing. Now move on to the glottis. Okay. So we have discussed the supraglottis. We have discussed the parts of the supraglottis. Okay. So I am just erasing all this that we discussed and we don't need it right now. So let us now come to the glottis. So what do we have in the glottis? In the glottis, you can see we have a pair of vocal folds, right? So we have a pair of vocal folds. Now these vocal folds, they, as I discussed earlier, they were known as true vocal cords. Now my question is, why they were known as true vocal cords? Okay, why they were earlier known as true vocal cords when they are clearly looking like a fold to us? Okay, so to answer this question, first let us study the layers of the vocal fold. The vocal fold is made up of 5 layers. What are the layers? Number 1, we have the non-keratinizing stratified squamous epithelium, right? Number 2, we have the lamina propria. The lamina propria is further divided into 3 more layers: the superficial layer of lamina propria, the intermediate layer of lamina propria, and the deep layer of lamina propria, right? And finally, we have the vocalis muscle. All right, so there are 5 layers of vocal fold. All right, so we saw the 5 layers. Now, remember the whole respiratory pathway. The whole respiratory pathway, starting from the nose, the nasal cavities, the paranasal sinuses, the pharynx, larynx, trachea, bronchi, they are all lined by pseudo-stratified ciliated columnar epithelium. As I told you, that is known as the respiratory epithelium. But the vocal folds over here, they are special because they are lined by non-keratinizing stratified squamous epithelium. Okay, so they are lined by non-keratinizing stratified squamous epithelium. All right, now the lamina propria. Okay, the lamina propria, let's look at the superficial layer of lamina propria. This consists of loose areolar tissue. So you see over here, this layer consists of the loose areolar tissue, and this layer is known as Rinke space. Okay, this space is known as Rinke space. And Rinke space, if we have edema, this is known as Rinke's edema. The Rinke's edema is seen in smokers. Okay, it is seen in case of smokers. Then we have the intermediate or the deep layer. Both these layers, the intermediate and deep layer, they combine, the collagen fiber in them combine to form the vocal ligament. Okay, and finally we have the vocalis muscle. So very easily we can remember them with the hand model. Okay, so what is the hand model? You can see that there are 5, 1 thumb and 4 fingers. Okay, so there are 5 layers of vocal fold. Number 1, we have the non-keratinizing stratified squamous epithelium. Okay, so you see the thumb is separate. It is different. So you see this layer is different from everywhere else. All right. Okay, we have a different epithelium. Now, you see a smoker, he holds the cigarette like this with the index finger, thumb, middle finger. So Rinke's edema, look at the index finger. The Rinke's edema is more common in smokers. So it affects the index finger. Okay. Then you see the maximum strength. Suppose you have to grip something. So the maximum strength that is given by the middle finger and the ring finger. So these 2 fingers, they will give you strength to grip something. All right. So same way, the intermediate layer and the deep layer, they form the vocal ligament. And finally, we have the vocalis muscle. All right. So hand model, these are the 5 layers of the vocal fold. Okay, now we go back to the previous diagram. When we look at this diagram, we have just studied the layers of the vocal fold, and with the knowledge we have gained, now we know that these vocal folds, they are lined by an epithelium. Which epithelium? We have the stratified, non-keratinizing stratified squamous epithelium. Okay, now in 1850, there was a singer. This singer had a curiosity. What was the curiosity? He wanted to look at the source of his voice. Okay, so he did an experiment. In that experiment, he attached a mirror to the stick and placed that in his mouth and then shined the light on that mirror. Now the mirror reflected the light onto the vocal folds. Okay, let's look over here. This is how he attached the mirror onto a stick and placed it in the mouth. And then he reflected the light on the mirror reflected the light on the larynx was illuminated. Okay, but something happened. What happened? Let's go back. What happened? You see, when the light came onto the larynx, most of the vocal folds, they are covered by the vestibular folds. So only this much part of the vocal folds received the light. Okay, and we know that the whole respiratory pathway is lined by the respiratory epithelium, but this part, the vocal folds, is lined by the squamous epithelium. And squamous epithelium shines white in the light. Okay, so what happened? It shined separate from the light. Okay, so this is how the vocal folds look like. You see, most of them are covered by the vestibular folds, and we can see over here that these are the white shining vocal folds. Now they look like cord, they look like rope. And when he saw them, he started singing. So these two, they started moving. So he thought that the sound is produced by the movement of these vocal cords. So they are cord-like structure. Okay, as we can see that these are the vocal folds, and they are covered on the two sides by the vestibular folds, one on each side on the vocal folds. Then anteriorly we have the epiglottis. All right. Okay. Now where the two vocal folds meet anteriorly, that is known as anterior commissure, and where they meet posteriorly, that is known as posterior commissure. Okay. What else can we see over here? In this, you can see over here that this part, you see, this is your arytenoid cartilage, right? And from epiglottis to arytenoid cartilage, we have over here the AE fold, remember? Okay, and from your hypopharynx topic, if you have studied, you know that around the larynx, on the sides of the larynx, we have an important area of the hypopharynx. This area I'm talking about, that is known as pyriform fossa. Okay, so that's on the sides of the larynx. In the hypopharynx, the pyriform fossa part forms a component of the hypopharynx, right? And this is what is visible to us in the technique now known as indirect laryngoscopy. Okay, so this technique, we have abandoned the name of, vocal cords, but we have kept the technique, and that technique is known as indirect laryngoscopy. Okay, so this technique of examination with the help of an indirect laryngoscopy mirror is known as indirect laryngoscopy. All right, now this between the two vocal folds, you see, this between the two vocal folds, this is the airway. We call it as rima glottidis. So rima glottidis is the area between the free margins of the two vocal folds, and that is the place from where we breathe. Remember, glottis is the narrowest part of human airway. However, you see, when we talk about human, we talk about adults. Okay, now in case of neonates, you see the larynx is funnel shaped like this. Okay, so in neonates, the larynx is funnel shaped. Therefore, the neonates, the narrowest part is the lowermost part, which is the subglottis, right? However, in adults, from the funnel shaped larynx, it becomes, tubular larynx. So therefore, glottis becomes the narrowest part. Okay, so subglottis, neonates narrowest part, glottis, adults narrowest part. Right? Now, a technique that we discussed in the pharynx to examine the larynx is the direct laryngoscopy. The direct laryngoscopy, as you can see over here, is done with the help of a direct laryngoscope. All right. So the image over here shows you a mesh direct laryngoscope, which is generally used by the anesthetist while endotracheal intubation, they visualize the larynx, they do a laryngoscopy, and then they inside the larynx into the trachea, they insert the endotracheal tube. Right? So this they do almost on the daily basis, multiple times. We in ENT surgeons, we also use a laryngoscope. That is a little different from this one. Okay, so that is generally done to do procedures and biopsies in the larynx. All right. Now, what I wanted to discuss with you is what is the difference between the indirect and the direct laryngoscopy. So as you know, indirect laryngoscopy you are doing with the help of an indirect laryngoscopy mirror. Direct laryngoscopy you do with the help of a direct laryngoscope. Now, what's the difference? Now, in the indirect laryngoscopy, you don't see the larynx. What you see is an image of larynx. Okay, so remember what you are seeing is an image of larynx. This image is virtual. Okay, this image is smaller than the actual image. Now, why don't we see the same size? Because we don't use a plane mirror. We use a convex mirror. So when we use a convex mirror, we can see a larger area with a smaller mirror. Okay, and it is inverted. Now many people will argue that a virtual image is an erect image. I agree. Now this image is anterior-posterior inverted. Okay, right? So virtual image, it's a anterior-posterior inversion. In direct laryngoscopy, we see an actual larynx. Right, actual three-dimensional larynx. Now, indirect laryngoscopy, ease of procedure. It can be easily done in case of in the OPD patients. Now, direct laryngoscopy, you require operation theater, you require anesthetist, and you require the anesthetist to give general anesthesia. All right, so it's an OT procedure. Now, indirect laryngoscopy, you can ask the patient to phonate. You see the vowels A, E, I, O, U. These are spoken from the larynx. So patient can speak them even with an open mouth. Right? So you ask the patient to phonate, and when the patient phonates, you can see the vocal fold movement. Direct laryngoscopy, the anesthetist has paralyzed the patient. So once the patient is under paralysis, you cannot see the vocal fold movements. Right? So that's not possible. So these are the advantages of indirect laryngoscopy over direct. However, the indirect laryngoscopy requires patient cooperation. You cannot do in children. Okay, whereas direct laryngoscopy, once you have given anesthesia, you can do in children and non-cooperative patient also. Okay, then indirect laryngoscopy, you cannot do additional procedure. Suppose there is a lesion, you want to take a biopsy. That cannot be done. It can be done only in direct laryngoscopy. Okay, moreover, indirect laryngoscopy, we cannot see the hidden areas of larynx, which can be seen in direct laryngoscopy. Okay, now, who can tell me what are the hidden areas of larynx? Okay, the hidden areas of larynx means the areas which cannot be seen in indirect laryngoscopy. So what are those areas? Number one, we have the ventricle. Remember? Okay, so we have the ventricle. Number two, we have the subglottis. Okay, number three, we have the anterior commissure. Very difficult to see with indirect laryngoscopy. Okay, number four, we have the laryngeal surface of epiglottis. Okay, you see the epiglottis is like this. There is a pharyngeal surface, there is a laryngeal surface. So once you are looking from above like this, you can see this pharyngeal surface, but you cannot see this laryngeal surface. Okay, and number five, what we cannot see in indirect laryngoscopy is the post-cricoid area. All these can be easily seen in direct laryngoscopy. Right? So all these can be easily seen there. Right? So this is the advantage of direct laryngoscopy over indirect laryngoscopy. Let's look at this image. This question was asked in the AIMS June 2020 exam. Identify the structure being marked as P. So what can we see over here? Let's look at this image in detail. This is the image of indirect laryngoscopy. Okay, so what can we see over here? We can see the vocal folds, right? And we can see the vestibular folds. Okay, covering the vocal folds, we have the vestibular folds. What else? you have the epiglottis. So you see this image is anterior-posteriorly inverted. Then we have over here the anterior commissure where the two vocal folds meet. We have the posterior commissure at the posterior end of the vocal folds, and you can see the A fold, right? Okay, and now what is B? The B is the piriform fossa. On the sides of the A fold, on the side of the larynx, we have the piriform fossa, right? So this structure was asked, what is B? The B is therefore the piriform fossa, right? Okay, so now we come back to this diagram, and in this diagram we have studied the glottis. Now in the glottis we have studied the vocal folds. Now we know in the vocal folds we have the vocal ligaments. I'm just drawing the structures that we have already studied, the layers of the vocal fold. We have the vocal ligament, and then lateral to the vocal ligament, you know, we have the vocalis muscle. Okay, so I'm just drawing the different layers over here. All right, so we have the vocalis muscle. Okay, now let's come to subglottis. What do we see in the subglottis? We see in the subglottis that there is no structure. There is no structure inside the subglottis. This is formed by a complete ring of cricoid cartilage. There is only airway. Therefore, if there is some disease in the subglottis, if there is a vascular malformation or there is a malignancy, there is a tumor, now it will present only when it grows and it blocks the airway. So it will present with respiratory difficulty, respiratory distress, or a sound produced due to this turbulent flow of air, which we call as stridor. Okay, so subglottis always produces stridor and presents itself. Okay, any disease in the subglottis, right? Okay, so that was our larynx that we have studied. Now before we finish, there are a few points here and there that I would like to discuss, and one important space. Okay, first of all, we saw that the two vocal folds, they have a stratified squamous epithelium. Now this junction where the stratified squamous epithelium meets the columnar epithelium, the pseudostratified ciliated columnar epithelium, that is known as arcuate line. That means we have two arcuate lines. Which two arcuate line? We have an inferior arcuate line, and over here you see we have a superior arcuate line, right? Okay, now I'm shading an area. You see, I am now shading an area over here. This area that I am shading in the yellow color on both the sides. Okay, so this area that I have now shaded on both the sides, this area, this is known as, yes, some of you might have guessed it, this is known as paraglottic space. Okay, so this space was left in the anatomy, paraglottic space. Okay, or you can call it as paraglottic space of Tucker. So what are the boundaries of paraglottic space? Let's look in this diagram. We have the anterior-lateral boundary. The anterior-lateral boundary is formed by the thyroid cartilage on the three sides. Anteriorly and laterally we have the thyroid cartilage, right? Okay, what about the superior medial boundary? As you see over here, the superior medial boundary of this space is formed by the vestibular folds along with the quadrangular membrane. Okay, so vestibular fold and quadrangular membrane. Now what about the inferior medial boundary? Now in the inferior medial boundary, you see there is a membrane. This membrane I am now drawing, I haven't drawn it earlier. So this membrane, it connects the vocal ligament to the cricoid cartilage. This membrane is known as conus elasticus. Okay, so it lines the inferior surface of the vocal folds. As you can see, it is lining the inferior surface of the vocal folds. We call it as conus elasticus, and it forms the inferior medial boundary of paraglottic space of Tucker. Okay, all right. Now what all we have drawn over here, let's look all of this in a colorful three-dimensional photograph. So as I told you, I have a photograph. I just wanted you to understand each and every structure of the larynx in this diagram, and then I'll take you to this photograph. Okay, let's look at this photograph. Let us first identify the structures. Okay, so that let's orient us to this photograph. This is the same photograph that we have just studied as a diagram. Okay, so what can we see over here? We can see the thyroid cartilage on two sides. Below the thyroid cartilage, we have the cricoid cartilage. Is that all right? Okay, so everyone has been able to identify the thyroid and cricoid cartilage. Okay, now let's look at this. This is the epiglottis right in front of you. Okay, and now we have the vocal folds. So these are the vocal folds. The part of the larynx which has the vocal folds, this is known as glottis. Above the glottis, we have supraglottis. Below the glottis, we have subglottis. Okay, so that's clear to everyone. All right. Now, what next do we have? Above the vocal folds, we have the vestibular or the ventricular folds. Remember, they were earlier known as false vocal cords, but that's a wrong name. Right? Now, these vestibular or ventricular folds, they enclose a space known as ventricle, which is the only true space of larynx. Okay, and inside these vestibular folds, we have a membrane that's known as quadrangular membrane. All right, so this membrane is known as quadrangular membrane. Okay, so this we have seen. Okay, what else we have seen? We saw a membrane covering the lower surface of the vocal folds, that is known as conus elasticus. Is that all right? Okay, so now let's look over here. We can see a yellow fat filled space. Where? This space which I have now just shaded. Okay, this space is known as paraglottic space of Tucker. Okay, this space is known as paraglottic space of Tucker. So what are the boundaries of paraglottic space of Tucker? We can see over here that the anterolateral boundary is formed by the thyroid cartilage. Right? The superior medial boundary is formed by the vestibular fold and quadrangular membrane. The inferior medial boundary is formed by the conus elasticus. Right? Okay, now look over here. Look over here. This is the epiglottis that we can see. This space, anterior medially, you see, this space, it goes anterior to the epiglottis, and anterior to epiglottis, we have pre-epiglottic space of Boyer. So remember, the paraglottic space of Tucker communicates with the pre-epiglottic space of Boyer. Remember, I told you pre-epiglottic space of Boyer is open laterally and communicates with paraglottic space. Right? Now you see, this paraglottic space of Tucker, it is in the supraglottic region, it is in the glottis, it is also in the subglottis. It is in all the three parts of larynx. So, if a malignancy goes inside the space, remember this is a potential space. It will become space only when something goes inside, like a malignancy. So, if the malignancy goes inside, then that malignancy will be considered to be involving all the three parts of the larynx. So, that malignancy will be known as transglottic malignancy. Okay, so any malignancy inside the paraglottic space is known as transglottic malignancy, and such a malignancy is staged as T3 stage. Okay, now pre-epiglottic space of Boyer is in direct communication with paraglottic space of Tucker. Therefore, any malignancy that goes to pre-epiglottic space of Boyer will also be considered as T3 stage, because there is direct communication, there is no distinction. All right, so that space will also be considered as T3 stage if the malignancy is in the pre-epiglottic space. Right? Okay, so that was the paraglottic space of Tucker. Okay, now let's do one thing. Let's take this paraglottic space of Tucker and let's draw a cross section. So what I'm going to do is, you see, this is the coronal cross section. We are looking at the coronal cross section from behind. Now I'm going to convert the coronal cross section into a axial cross section. Okay, I'm going to convert the coronal cross section into a axial cross section. So what do we see on the sides? You see, on the sides over here, we see the thyroid cartilage. Okay, so you see the axial cross section. This is the thyroid cartilage, right? Okay, now what is inside? So that was the anterolateral cartilage. Okay, what is inside? Inside we have the epiglottis and the membrane. Which membrane? The quadrangular membrane. Let's go back and have a look over here. We can see over here that this is the thyroid cartilage on the two sides anterolaterally, and when I have done a cross section, we can see the epiglottis, and then there is a membrane that's known as quadrangular membrane, right? Okay, so we have the thyroid cartilage, we have the epiglottis and the quadrangular membrane, right? Okay, now posteriorly we have something on the sides of the larynx. What is that? That is the pyriform fossa, right? So this over here, this is the pyriform fossa. And now if I shade this area, you see, if I shade this area, where is this area? You see, anterolateral boundary is the thyroid cartilage, and the medial boundary, what we can see over here, is the quadrangular membrane. This is our paraglottic space. And remember, the paraglottic space, it communicates with the pre-epiglottic space. The pre-epiglottic space is open laterally, and there it communicates with paraglottic space, right? So they are in communication with each other. All right, you have also noticed that the posterior boundary of the paraglottic space over here is the pyriform fossa. So remember, the pyriform fossa, it forms the posterior boundary of the paraglottic space, right? So this is the paraglottic space axial cross section. We have converted the coronal into axial. Okay, at one particular point we can see the two spaces, pre-epiglottic and paraglottic, together. Okay, so let us study the nerve supply of larynx. It is a very easy topic. In fact, we have already studied this topic when we studied the embryology of larynx. So we know that the larynx as a whole is supplied by the vagus, the 10th cranial nerve. Okay, now this vagus has two terminal branches, superior laryngeal nerve and recurrent laryngeal nerve. You see the superior laryngeal nerve near the hyoid bone, you can see it further divides into two branches. The external branch, which remains outside the larynx, that's known as external laryngeal nerve. And there is a branch which goes inside the larynx, that is known as internal laryngeal nerve. Now the external laryngeal nerve stays outside and it supplies the cricothyroid muscle. Remember, the only muscle which is formed by fourth arch and supplied by superior laryngeal nerve. The internal laryngeal nerve goes inside the larynx and it gives sensory supply to supraglottis. Okay, so remember, we have a cuff reflex over here. Any foreign body tries to go inside the airway, it will stimulate the internal laryngeal nerve in the supraglottis. Immediately, the internal laryngeal nerve will give a stimulus, and that will lead to spasm of all the muscles. It will close the airway, and then the air blast coming from below will open the airway with a blast, and the foreign body is thrown out. We call it as cuff. So remember, the cuff reflex is generated due to internal laryngeal nerve. Okay, now remember, in the ear I taught you, if you do vigorous ringing, okay, then the cuff reflex is generated by auricular branch of vagus, which we also call as Arnold's branch of vagus. So cuff reflex normally is generated due to internal laryngeal nerve, but cuff reflex during vigorous ear ringing or manipulation of the ear by a probe is due to the Arnold's branch of vagus. Okay, now let's look at the recurrent laryngeal nerve. The recurrent laryngeal nerve it goes from below. We remember in the pharynx, it goes inside, below the inferior constrictor muscle, below the cricopharyngeus. It goes inside and it supplies all the intrinsic muscles of larynx, except, of course, cricothyroid muscle. And it also gives sensory supply to subglottis, right? Okay, so now sensory supply of supraglottis is by internal laryngeal nerve. Sensory supply of subglottis is by recurrent laryngeal nerve. What happens at glottis? You see, at glottis, the internal laryngeal nerve from above, from the supraglottis, the recurrent from the subglottis, both of them combine to form Galen's anosmosis, and this Galen's anosmosis supplies the glottis. So glottis is supplied by Galen's anosmosis. This is a anastomosis of two nerves, internal laryngeal nerve from the supraglottis and recurrent laryngeal nerve from the subglottis. Okay, together these two nerves, they supply the glottis, right? Okay, this was the nerve supply of larynx. Let's go back and study some embryology. Let us discuss the development of the aortic arches. Very important to understand the nerve supply of larynx. Let's discuss this development of aortic arches. Now we can see the right and the left dorsal aorta and the right and left arches and the blood supply. Okay, now we can see the aortic sac that forms the ventral aorta. We can see the fusion of the dorsal aorta and the right and left intersegmental arteries. Okay, so these are the embryological structures present. Now what happens to these structures? You see, on the right side, the fifth and the sixth arch arteries, they disappear. Fifth, we know the arch and the artery, everything disappears. So on the right side, the sixth arch artery as well as disappear. Okay, whereas on the left side, you see the sixth arch artery, it forms the ductus arteriosus. Okay, so you can see the right recurrent laryngeal nerve, the left recurrent laryngeal nerve, and we can see the ductus arteriosus formed by the sixth arch artery, right? So we can see the ductus arteriosus over here. All right, now because of this ductus arteriosus, you can see the left recurrent laryngeal nerve has to go down and take a turn around this ductus arteriosus. So recurrent, going down and coming back, right? Whereas on the right side, you can see that the sixth arch artery as well as the fifth arch artery, both of them disappear. So it comes to lie over here and it takes a turn around the right subclavian artery, right? Okay, now let's look over here. The ductus arteriosus in the later age after birth forms ligamentum arteriosum. So let's look in this diagram. We can see the arch of aorta, we can see the left common carotid, and that gives rise to the external carotid artery and the internal carotid artery. Now what do you see? You can see that on the right side, from this arch of aorta arises the brachiocephalic artery. Okay, and that gives rise to the right subclavian artery. Okay, whereas on the left side, the left subclavian artery arises directly from the arch of aorta. Now because of this arrangement, you see the ligamentum arteriosum over here is still present, which attaches the pulmonary artery to the arch of aorta. Okay, so we still have this ligamentum arteriosum. Now the recurrent has to take a turn around it. It does not disappear. So therefore, in adult age, you will see that the left recurrent laryngeal nerve has to go into the thorax. It is a longer course. It takes a turn around this arch of aorta. Actually, it is taking a turn around the ligamentum arteriosus and it comes back. It has a longer course. Whereas on the right side, the right recurrent laryngeal nerve takes a turn around the right subclavian artery, right? Okay, so it has a shorter course. Now because of this, if there is any cardiothoracic surgery, the left recurrent laryngeal nerve has more chances of injury. Okay, in case of any cardiothoracic surgery, the left recurrent has more chances of injury. Okay, now this is the posterior view of the neck. Okay, we can see the trachea, we can see the thyroid gland, and we can see the right and the left recurrent nerve. Look at the left one. It is coming back from the arch of aorta. Now the right one is coming back from the right subclavian artery. Now the right one therefore is more superficial. Okay, the right one is more superficial. Therefore, if we do a neck surgery such as a thyroid surgery, okay, so if we do a neck surgery such as a thyroid surgery, the right recurrent is more commonly injured as compared to the left recurrent. Left is more commonly injured in the cardiothoracic surgery. Okay, but in the neck surgeries, right is more commonly injured. Okay, but somebody asks you which is the most common nerve injured in thyroid surgery. So remember, you see over here, the most common nerve injured in thyroid surgery is not recurrent. It is actually the external laryngeal nerve, which is a branch of the superior laryngeal nerve, and this injury most of the time goes unnoticed. But this is the most common nerve injured in thyroid surgery. Clear? Okay, so these are a few MCQs that you must know, and they are asked frequently in the exam. All right, let's look over here in the question. Left recurrent laryngeal nerve has a longer course because of which arch artery? Now we know answer is sixth arch artery, which forms the ductus arteriosus, and later on it forms the ligamentum arteriosum. So it was asked as recent as the PG Jan 2020 exam. Okay, next question. Recurrent laryngeal nerve supplies all except cricothyroid. Okay, so we discussed cricothyroid is supplied by superior laryngeal nerve. Which branch? External laryngeal nerve branch of superior laryngeal nerve. Next question. Which of the following structures has least chances of injury during thyroid surgery? Okay, so recurrent laryngeal nerve, superior laryngeal nerve, ansa cervicalis, marginal mandibular. So we know that out of the two, superior laryngeal nerve gives the branch external laryngeal nerve, which has the maximum chances of injury in the thyroid surgery. Okay, so external followed by, you see, the right recurrent is more common as compared to the left recurrent in thyroid surgery, I'm saying. Okay, now what about ansa cervicalis and marginal mandibular nerve? Let's look at them. So you see over here in this diagram, you can see the ansa cervicalis. Now, ansa cervicalis is a group of nerves that arise from the cervical plexus, and this is also known as ansa hypoglossa. It is just superficial to the internal jugular vein in the carotid triangle. So you can see it is very near to the thyroid gland, and it can also be injured sometimes in the thyroid surgery. Now, let's look at the marginal mandibular nerve. Now remember, the extent of the exposure for the thyroid surgery is from the hyoid gland to the sternum. This is the extent of the exposure in most cases, until unless we have an unusually large thyroid. In those cases also, the unusually large thyroid tends to extend inferiorly. Right? The marginal mandibular nerve is way above, you can see it's above the hyoid bone. So this is not the place we will go and do the surgery. So this has the least chances of injury in case of thyroid surgery. However, marginal mandibular nerve is a commonly injured nerve when you do a submandibular gland surgery. Remember, submandibular gland is over here. Okay, so above that submandibular gland, we have the marginal mandibular nerve. So this is one of the most important nerves when we are going to do the submandibular gland surgery. Okay, however, in case of thyroid surgery, our extent of exposure is generally up to the hyoid bone. So this nerve is generally not the nerve that will come across to us in the thyroid surgery. So answer to us is the marginal mandibular nerve. Okay, so let us now discuss the muscles of the larynx. So let's look at this diagram. Now this diagram is to demonstrate all the intrinsic muscles of larynx. Now, what can we see in this diagram? This is a axial cross section. We can see the thyroid cartilage. Okay. Now, below the thyroid cartilage, we have the cricoid cartilage, a complete ring that is also visible to us. And we can also see the arytenoid cartilage. This is the vocal process of arytenoid, and we also have the muscular process of arytenoid. Now, these are the cartilages that are visible in this diagram. Let's look at the muscles. So, from thyroid to arytenoid, we have the muscle. We know the name, easy to remember, between the two structures, thyroarytenoid. Club the name, thyroarytenoid. Right? Now, between the cricoid and arytenoid, you see, cricoid and arytenoid, on the lateral aspect, we have a muscle. This is known as lateral cricoarytenoid muscle. Okay, so this is your lateral cricoarytenoid coming from cricoid to the muscular process of arytenoid. Right? Now, similarly, going from cricoid to arytenoid on the posterior aspect, you see, on the posterior aspect, we have a muscle that's known as posterior cricoarytenoid. From cricoid to arytenoid, posterior cricoarytenoid. Right? Okay, and we can see over here a muscle between the arytenoids, and this muscle is known as interarytenoid muscle. As you can see, interarytenoid is the only unpaired intrinsic muscle. Okay, this is the only unpaired intrinsic muscle of larynx. All right, now let us discuss each of these muscles and their functions one by one. Shall we? All right, so let's go to the first muscle. The first muscle that we are discussing is the lateral cricoarytenoid. Now, before I start with the discussion of these muscles individually, just remember one rule. What is the one rule? What is the primary function of larynx? Now, many students think the primary function is phonation. No. The primary function of larynx is protection of airway. Okay, phonation, voice production, is the secondary function of larynx. You see, if you don't speak for 1 day, 2 days, few days, it will not matter. But if a foreign body goes inside, within a few minutes you will die. So the more important function is protection of airway. This is the guardian of the lower airway. It does not allow any foreign body to go into the trachea. If the foreign body succeeds, you will die. So it does not allow the foreign body to go in. All right. Now, to do this function, all the muscles of the larynx are adductors. Okay. Anything tries to go inside, they close the larynx. Okay. So all muscles of larynx are adductors except one muscle, that is our posterior cricoarytenoid. Okay. So all are adductors except posterior cricoarytenoid. This is the only abductor of larynx. Okay, only abductor of larynx. So this is the rule. Remember this rule. And now we start with the discussion. Okay, so we come to the lateral cricoarytenoid muscle. Okay, now we can see over here the green color muscles. I have highlighted them in the green color. This is your lateral cricoarytenoid muscle. Okay, now let's look at them in the other cross section. You can see over here, going from cricoid cartilage to the arytenoid cartilage, to the muscular process of arytenoid cartilage, we have the lateral cricoarytenoid muscle. Okay, so this is how the muscle looks like. Okay, so going from cricoid to arytenoid. Now what happens when this muscle contracts? Okay, let's look in this video. So when this muscle contracts, what happens? You see, it rotates the arytenoid. So it rotates the arytenoid and it brings the two vocal folds together. Okay, so it causes adduction. You see, the lateral cricoarytenoid, it causes adduction. Now, let's look at the transverse arytenoid. So the transverse arytenoid is also known as interarytenoid. It is between the two arytenoids. And as I told you earlier, this is the only unpaired intrinsic muscle. Okay, and you see it has bilateral innervation. It is supplied by which nerve? It is supplied by recurrent laryngeal nerve. Both the right side and the left side. Okay, so both the recurrents, the right and the left, they supply the transverse arytenoid muscle. Okay, so this is the only unpaired muscle and is supplied by both sides, the right and the left recurrent laryngeal nerve. Clear? All right. Okay, now this is the interarytenoid or transverse arytenoid. Now let's look in this diagram. You can see over here this green color. This is the transverse or interarytenoid. Now what happens when this muscle contracts? You can see clearly when this contracts, it brings the two arytenoids together and it causes adduction. Clear? Okay, we can also watch in the video. We can see that when the transverse arytenoid contracts, it brings the two arytenoids together and causes adduction. Right? Okay, so we come to the next muscle, the posterior cricoarytenoid muscle. Now this diagram is asked in the exam. It has been asked many times in the exam. Okay, so let's look at this diagram. We can see the epiglottis, we can see the thyroid cartilage, we can see the cricoid cartilage. Right? Now, from the cricoid cartilage posterior surface, we have this muscle, posterior cricoarytenoid muscle, PCA, posterior cricoarytenoid muscle. It is going to the muscular surface of muscular process of arytenoid cartilage. Okay, so this question is asked in the exam. Identify the structure. So you should know where is the posterior cricoarytenoid muscle. This is the posterior most muscle of the larynx, posterior most intrinsic muscle. Okay, so this is the posterior cricoarytenoid muscle. Right? Now, what happens when this muscle contracts? When it contracts, it opens the airway. So, this muscle, this is the only abductor of larynx. It is the only abductor of larynx. Okay, let's watch this video. Okay, now what do we see? The arytenoids are rotated and you can see the airway is open. Remember, all the muscles, they are to close the larynx. But this is the only muscle which later on opens the larynx and it helps us breathe. Okay, so this is like a safety guard. All other are closing, but somebody has to open so that you are able to breathe. So therefore, this is the safety muscle of larynx. Okay, if it will not open the airway, we cannot breathe. So this is the safety muscle of larynx, posterior cricoarytenoid muscle. Right? Okay, question asked, abductor of vocal folds is, answer we know, posterior cricoarytenoid muscle. Okay, next question, life-saving muscle of vocal cords is. So remember, life-saving muscle of vocal cords is posterior cricoarytenoid. So that's the one which will open the airway when all the muscles will close it. Right? Okay. Next, we come to the thyroarytenoid and vocalis muscle. So thyroarytenoid. From thyroid to arytenoid, we have the muscle thyroarytenoid marked in green color. Now remember, what is vocalis? Vocalis is in fact the medial fibers of thyroarytenoid. So you see over here, I have marked these medial fibers separately. So these fibers are inside the vocal folds. So therefore, they are known as vocalis. So vocalis is nothing but the medial most fibers of thyroarytenoid muscle. Right? Okay. So this is the thyroarytenoid muscle that you can see in the second photograph also. Now, what happens when this thyroarytenoid contracts? You see, when the thyroarytenoid contracts, they bring the epidiameter closer. Okay, so they close down the anterior posterior diameter and they close the airway. Okay, so let's look over here. The thyroarytenoid contracts and they bring the arytenoid closer to the thyroid cartilage. So now, when this happens, what do you see? What happens? Not only there is adduction, but you see the action of vocalis muscle. You see, when the vocalis brings the arytenoid closer, what happens? The vocal folds, you see the action of the vocalis muscle, it makes the vocal folds these vocal folds are made shorter. And if you have noticed, they are made more thick. Okay, and if you notice, their ends, their margins, they will become broad. Okay, so margins will become broad and they relax. Okay, the vocalis muscle relaxes the vocal folds. So they not only become thick, okay, they become short, the margins become broad and they relax. So remember, vocalis is the relaxer of vocal folds. This question is asked, vocalis muscle is the relaxer of vocal folds. Right? Okay. Now, which muscle is left for us to discuss? The muscle which is left for us to discuss is the cricothyroid muscle. So remember, this is the intrinsic muscle which is on the external surface of larynx. As you can see, it is attached between the cricoid and the thyroid cartilage on the anterior most surface. So now what happens when the cricothyroid muscle contracts? Okay, so to understand that, let us look at this cross section. So I'm drawing this cross section to make you understand that this, you can see, is the cricoid cartilage. Okay, so this is the cricoid cartilage. On the cricoid cartilage, we have the arytenoid cartilage, right? Okay, so that we all know. From the arytenoid cartilage, we have the vocal fold that goes and attaches to the thyroid cartilage. All right, okay, so that is clear to everyone, right? Now, from the cricoid cartilage on the anterior surface, we have a muscle, which is the cricothyroid muscle. It is on the external surface. Now, what happens when this cricothyroid muscle contracts? It pulls the cricoid cartilage up anteriorly. You see, because of this pull, the cricoid cartilage, it rotates. It comes to lie like this. Okay, so it comes to lie like this, it rotates. And when it rotates like this, because we have just pulled the anterior end of the cricoid cartilage, it has rotated up. You see, because of this rotation, now what do you see? Because of this rotation, you can see that the arytenoid cartilage goes back, and when the arytenoid goes back, the vocal fold over here, this is stretched. Okay, so you can see the vocal fold is stretched. So as a result of the contraction of the cricothyroid muscle, the vocal fold, it becomes longer. Okay, so when it becomes longer, what happens? It becomes thin. All right, and the margins become sharp. All right, and the tension in it increases. Okay, so therefore cricothyroid muscle is the tensor of the vocal fold. Okay, cricothyroid muscle, this is a tensor of vocal folds. As I always tell my students, you see, the tension is always given by outside people. You see, you go to your home, your mom, what will she do? She will take away your tension. She will tell you to relax. Okay, so when you go home, you feel relaxed, your tension goes away. All right, now you meet your mom, she'll make you eat food. So you will become fat, right? So you see, you go home, people inside your home, they make you relax. Your mom, she makes you relax and takes away your tension. Okay, you are relaxed and you become thick. So remember, vocalis is inside, relaxes the vocal folds, makes it thick. Okay, now you are in your home. Now your neighbor auntie comes. She talks to your mother. She says, oh, your son is still studying. When will he do the internship? Now the new pattern paper is coming. How will he clear? How will he prepare? So you see, the auntie is not saying anything to you. Your neighbor, she is not saying anything to you. She is just saying things to your mom. And because of that, your tension increases. So people who come from outside increase your tension. So similarly, cricothyroid is outside on the outer surface. And it is not saying anything to the vocal fold. It is just pulling the cricoid. So as it pulls the cricoid, the tension in the vocal fold increases. Right? So cricothyroid is the tensor of the vocal fold. And this question is asked, which is the tensor of vocal fold? Answer is cricothyroid muscle. Right? Okay. Now, to finish this topic, let us discuss a condition known as phonesthesia. So I've discussed all these muscles of the larynx. So what is phonesthesia? Phonesthesia is vocal fatigue. Okay. So when one of these muscles undergo a fatigue, we have a condition known as phonesthesia. Okay. Now let's say the thyroarytenoid muscle, it undergoes phonesthesia. Okay. The thyroarytenoid muscle has undergone phonesthesia. Now what will happen? Because of this, you see the arytenoids, they are brought together by the interarytenoid muscles. But now because the thyroarytenoid is not working, we have a spindle-shaped gap over here. Okay, so there is a gap over here between the two vocal folds when they are adducted, and this is a spindle-shaped defect. Okay, so this spindle-shaped defect is seen in thyroarytenoid phonesthesia. Right? Okay, now let's say the thyroarytenoid is working properly, but the interarytenoid or the transverse arytenoid has undergone phonesthesia. Okay, so we have lost this function. We have lost this function, right? These are not coming together. Okay, so what happens now? The arytenoids, they are rotated by the lateral cricoarytenoid and the thyroarytenoid. Okay, so anteriorly you can see that they are together, but posteriorly we can see that there is a triangular gap. Okay, so this triangular gap, a posterior triangular gap, is seen in transverse or interarytenoid phonesthesia. Okay, posterior triangular gap seen in transverse or interarytenoid phonesthesia. Okay, now let's say there is a phonesthesia of both thyroarytenoid and interarytenoid. Okay, so both these muscles, they have undergone phonesthesia. So what happens as a result? Okay, there is only the movement of the lateral cricoarytenoid. Okay, so there is only movement of the lateral cricoarytenoid. Rest, there is no movement. So what happens as a result? Now as a result of that, we have over here a space. Okay, so between the two vocal folds on a trying adduction, now what happens? There is a gap. This gap, you can see as I am drawing, this gap is in the shape of a keyhole. Okay, so this is known as keyhole appearance of glottis. Okay, and this keyhole appearance of glottis is seen in phonesthesia of the both thyroarytenoid and interarytenoid. Okay, so that is known as keyhole appearance of glottis. The treatment of phonesthesia is voice rest followed by speech therapy. Okay, so you have to strengthen the muscles also so as to prevent further fatigue. But first you have to give speech rest or voice rest. So voice rest followed by speech therapy, that is the treatment for phonesthesia. Right? Okay, so that is how we can demonstrate the different actions of these different intrinsic muscles of the larynx.